welcome everybody.
Hi, James.
Hello, everyone.
Hi, everybody.
So good to see everybody. We're still letting a couple folks in. We always have a big audience when we have a physician presentation. So give us a moment while people all get in the Zoom room and get settled. But we're so glad everybody's here. What a great group today. Look at everyone. I think we can go ahead and get started and go through our introductions and say hello. I just want to say hi. I'm Chris Pikarski. I am the president and on the board, and nice to see everybody here today for a physician presentation. Why don't I introduce the team real fast? Adele, did you want to say hi?
Sure. Hi, everybody. Adele Jason. I'm the vice president of our board, and I'm a 10-year survivor.
Fantastic. Charmaine, you want to say hello?
Yeah, Charmaine in Austin, Texas, a 24-year survivor, also on the board and volunteer.
Thank you. And then Connie, would you like to say hello?
Hi, good morning. I'm residing in Fort Lauderdale, and I am a volunteer, and my husband is a 7-year survivor. Welcome. Good morning.
Fantastic. And then Jamie, you want to say hello?
Hi, everybody. I'm Jamie. I am in Oregon, and I am a 3-year survivor, and I'm just so happy to be here.
And Ramsey, that's Ramsey there in her lap.
And this is Ramsey, apparently our mascot.
Awesome. And then last but not least, James, you want to say hi?
Hi, everyone. Welcome. James Caldwell from Northern Ireland. I'm an 8-year survivor from a high-grade appendix cancer. I'm also an admin on the Facebook group. Good to see everyone.
Good to see you here, man. Thanks for being here. Adele, you want to run through the introduction?
Yeah, absolutely. So, so we have a few disclaimers. Jamie's going to pop up our slides. Okay, again, we're so happy you're all here. So PMP Pals is the world's oldest global volunteer-run organization, giving hope to patients fighting appendix cancer, PMP. Okay, and we provide this forum to provide fellowship and support to our patient and caregiver group. We're not licensed physicians, although we do have a guest presentation today. Participation in this may disclose your identity. You're welcome to turn off your camera, change your name, but we can't guarantee anonymity. And then, by participating, we do record these calls. So by participating, you're agreeing to allow us to record these. You may see some images in our presentation today that are scary. So, we'll give you advance notice and feel free to look away. And then, what we'll do for today's call, if you have questions, feel free to put them in the chat. We'll do a Q&A session after Dr. Gangi is done with her presentation. Feel free to stay as long as you're able to, and we're just happy you're here. And then as a reminder, PMP Pals, we have a lot of programs. We do these Zoom calls twice weekly. And, every few weeks or so, we do have a surgeon guest presenter, which is today. We send our Bare Bottom Bear program, sign up for a bear if you're in need of some comfort. Info at PMP Pals. If you have a question, don't hesitate to reach out to us. Ask Arthur. Arthur is a patient and a retired pediatric surgeon, and so he does field some more of our medical questions. Our most popular program is our card program. Feel free to sign up for cards, and it really is overwhelming to get notes of hope from patients around the world. And also we send out our PALS starter kit. So feel free to sign up on our site for a starter kit as well. We are volunteer donations run. So we certainly would appreciate any donations you could make through PayPal on our site or through Amazon Smile. So with that, and again, stay connected with us during the week, either on Facebook, Twitter, or through our website. So with that, I am going to turn it over to Paul Cohen to introduce Dr. Gangi. Paul is a patient of Dr. Gangi's and a great participant in PMP Pals.
Good morning, everybody. I'm here in Calabasas, California. And I'm almost a 2-year successful survivor of MOAS and HIPEC. I've learned quite a bit of Latin with Alex's assistance through this process. I spoke with Alex earlier this week and told her that I had the privilege of introducing her to the group. Her reply to me immediately was, should I be worried? And my reply was, no, just be yourself. And I reminded her that you're smart, articulate, experienced, witty, accomplished, educated. You're Alex. I'm sure that we all remember the words, you have cancer. Our worlds tend to collapse. And for me, it was a feeling of fear and despair. And I kept saying, why me? And it became really apparent, why not me? And it was here that the journey, as we call it, or keep on trucking, began. Sherry and I met Alex in December of 19. This was post-appendix removal and a 2-week visit to Tarzana Providence Hospital. And it was here that everybody, and I mean everybody, in the San Fernando Valley that visited with me said that Alex Gangi was the absolute best. I asked Dr. Gangi when we met with her at her office, what was my forecast? And she said to me, as she sat up in her chair, and this was with no mask, as this was all just before COVID, and said to me, almost quote, that her work came with a 20 to 25-year warranty. I quickly did the math, and that got me to about 85. Oh my God. Sherry and I were convinced on the spot that she was the right doctor to have on my team. No second, no third opinions, no more research, no more shopping. Let's just do it. But COVID unfortunately had its plans. And finally, I checked in at Cedars in August of 20. And here I am today with our favorite initials, everybody, NED. Alex is a graduate of the University of California at Irvine and completed her med degree at Drexel University. She speaks 4 languages. Geez Louise, I've got problems with the command of the English language, let alone 4 languages that Alex speaks. Alex joined the faculty at Cedars Sinai in 2017. She completed her surgical oncology training at H. Lee Moffitt. And Anne, I'm sure you know where H. Lee Moffitt is. And she specializes in surgical management of, forgive me if I don't say this correctly, hepatopancreatico biliary malignancies, metastatic colorectal cancers, and sarcoma. Oh my God. Her research focuses on understanding the role of the tumor microenvironment for metastatic NETs, liver toxicity, while improving tumor-specific responses. She's involved in numerous translational and clinical research projects examining comparative effectiveness and various surgical and medical treatments in gastroesophageal and HPB malignancies. She absolutely wears so many hats. I'm surprised that she keeps everything straight. No politics involved. A cliche was created a number of years ago. It takes a village. Alex is the leader of this village, along with all of her surgical team at Cedars Sinai, the staff, the nurses, and all the caring people. I often refer to her as the Christ, the light, and the way. I'm here today because of her surgical skills, her intelligence, her focus. Most of all, Alex is a trusted friend, and I feel that I can call upon her for almost anything medical. And yes, she returns calls, texts, and emails in lightning speed. Oh, Alex is also a dog lover. Welcome, Dr. Alexandra Gangi.
Thank you very much, Paul. When I asked you, should I be worried? It was more a question of, should I be worried about your introduction? But thank you for being very kind. I'm happy to be here. And Paul has been pushing me to try to join you guys for as long as he's been a member of PMP Pals. And every time there's a physician speaker, he'll reach back out and say, today we heard from so-and-so and you should be on it. And today we heard from so-and-so and you should do it. Today we heard from this other person. So Paul, I'm happy to be here with you and everyone else. And I have, I'll try to go through, I have a talk that we generally give to practitioners who don't have any concept of what pseudomyxoma or appendiceal cancer really is. And I'll try to go through some of that with you, as you guys are all fairly well versed in terms of all of this. And then certainly we can pause for questions. And this is meant to be interactive. So if I'm saying something that doesn't make sense or you want more clarification or need me to stop, please feel free to stop me. I'll try to be aware, mindful of the chat as things come through. All right, so let's see. I have no financial disclosures. So today I'll try to go through kind of introduction to cytoreduction and HIPEC, patient selection, some technical aspects. In that segment, as Adele mentioned, I'll have some pictures that have been modified, hopefully not to disturb you all too much. Program building, and this is really kind of program building for you guys as the patient, what that should entail and who your patient care team should be, and then future directions for HIPEC. So we think that there are really three main pathways through which peritoneal carcinomatosis can develop. This isn't specific necessarily to appendix cancer, but really all cancers that ultimately spread to the peritoneal cavity, appendiceal malignancies not being excluded. One is that the primary tumor can actually be peritoneal. So there are subtypes of cancers like peritoneal mesothelioma, and other types that essentially are primary peritoneal cancers, meaning it didn't actually come from anywhere. The peritoneum created the cancer. There are other types of tumors where it's dissemination from the primary tumor. This is typically what we see with the majority of the appendiceal cancers. It means that either pieces have kind of broken off, or the appendix can actually erupt, and then you can have dissemination from the primary tumor. And then the third molecular pathway, which is less well understood, means that you can have independent origins of the primary tumor and peritoneal implant. So this is more typical of things for like colorectal cancer, or some of our gastric cancers, or pancreatic cancers. So the adenocarcinoma varieties, sometimes there's no actual direct mechanism of spread from where the tumor originally started to the peritoneum, but clearly it got there somehow, and we don't know exactly how one went to the other. The same way that something can go to a lymph node or to the lung or to the liver. That's kind of the third mechanism that we're talking about. So frequently when I'm seeing patients in my office, they're asking, well, how did things get to where they got, and why are they always in the same places, or do you typically find them in the same places? Why is everyone always talking about the pelvis? Why is there stuff above my liver, et cetera, et cetera. So if you kind of look at this is the way that we look at the abdomen when we get in there. So basically your colon is this inverted U-shaped thing. Your appendix is hanging off here into the pelvis. And you can just imagine that if it is coming from your appendix, and this is a typical Lammin or Hammond or some kind of mucinous malignancy that resulted in some perforation, you would expect that all of that mucinous stuff will kind of sit in the pelvis. That kind of makes sense, right? Because it's right next to it. But the reality is that a lot of this stuff is actually quite gelatinous and fluid to some degree. And so if you kind of follow these arrows back in the 1970s, a physician by the name of Morton Myers tried to figure out exactly how peritoneal carcinomatosis distributes itself. So what he ultimately did is he recreated ascites in 35 hospitalized patients. Be happy that you weren't in the hospital 1970. But he then, in creating this ascites, he treated them with nitrous oxide and meglumine, which is a contrast medium, in small increments. And then he would basically x-ray these patients, right? The way they were standing, sitting, lying down, et cetera, et cetera. And what he noticed was that the pattern of where the fluid kind of shifted followed these arrows, right? So the ascites most typically, almost always, was dependent in the pelvis, right? And that makes sense because typically you're standing or sitting, so that's where things are sitting. And then when you'd be lying down, it would kind of follow this upward arrow and go into this area of the lesser sac, kind of surround the liver, and then find the free spaces kind of up along the diaphragm. So a lot of the mid-abdomen would actually be spared because that's just not where things sit. So a lot of times when we're doing diagnostic laparoscopies, or we're looking, the things that we'll frequently miss are kind of things here back behind the liver, things along the spleen. I think a good number of patients are always like, why are you taking my spleen? There's nothing up there. It's like in the polar opposite side of my appendix. How did things get up there? And you just have to kind of think that's how fluid flows in the abdomen. So this is sometimes a graphic that's helpful for people to understand that, you know, we're not going into all these spaces because, you know, we're bored in the operating room, but this is actually where the disease sits. And the thought behind HIPEC is really that it's kind of a loco-regional treatment for a loco-regional disease. So we know that certain types of cancers have a predilection to spread to lymph nodes and other organs. A majority of these mucinous appendiceal malignancies don't really do that. As I mentioned before, you know, they perforate and then they kind of spread all of their mucus, but they don't really have the ability to spread into lymph nodes or other organs. Which is why the survival rates are so good, and which is why systemic chemotherapy isn't really effective, because you can imagine that if we're giving you typically chemotherapy through the blood, and again, I'm talking about appendiceal mucinous neoplasms, I'm not talking about adenocarcinoma, goblet cell appendix cancers, I'm not talking about that variation yet in making some of these statements. We'll get to those a little bit later. But you can imagine that the chemotherapy can't really get through the vessels into the deposits that are sitting there or the mucus that's kind of floating around in the belly. So all of this, the thoughts behind locoregional treatment for locoregional disease came from some of the work that Judah Folkman did. And he essentially was looking at tumor growth in the cornea of rabbits. Cornea is that part of your eye. And that part doesn't have any vessels. That's what avascular means. And so what he found when he was studying metastatic disease was that early on, metastases are diffusion dependent and they kind of grew at a linear rate. So what that means is if you basically take a cell and I put it in like a petri dish and I give it all sorts of things that it needs to survive, it'll just grow because it sucks those things up, right? But ultimately, once tumors hit this 2.5 millimeter size, well, then these vessels started to grow. And once vessels started to grow, then they kind of grew very, very quickly, kind of exponentially, because then they were fed not only by diffusion mechanisms, but the blood fed them and they kind of ate the nutrients that your body was providing them. And these can grow quickly. These can also be treated with systemic therapy. So this is where the thought of systemic therapy for things like appendiceal adenocarcinoma comes in. But the thought was that, well, we can see things that are this big, typically 2.5 millimeters or greater. And if so, surgery can remove the really big ones that have systemic circulation. Why can't we treat the things that we can't see that are really, really small at 2.5 millimeters? We know that they're diffusion dependent. So why can't we put something in there to kill those things, right? Because they don't have any vessels and it's just what they're sitting in. So that was kind of the thought process. So Dr. Weisberger in the 1950s introduced the concept of intraperitoneal chemotherapy, and here it was really more palliative, and this was for all comers, all types of patients with different kinds of peritoneal malignancies who developed, you know, really big refractory ascites. For some of you, you may have noticed that before you had your surgeries, or, you know, if you're being considered for surgery now, you've noticed over time that you may kind of have a bigger belly that you can't really explain. And, you know, some people say, well, I just thought I was gaining weight over the last 10 years, 5 years, et cetera, et cetera. So for some malignancies, this ascites, or the fluid that could develop in the abdomen, is a little bit more aggressive. Like if you have peritoneal carcinomatosis from gastric cancer or pancreatic cancer, it works a little bit differently than PMP and mucinous malignancies of the appendix. And so one of the ways we thought that we could treat that was to basically drain out all that fluid and then put in chemotherapy in the belly and hopefully slow down the growth of those different types of cancers. And that's what we mean by palliative. It wasn't a curative thing. It was something that we tried to do to improve patient symptoms. And then following that, Dr. Diedrich actually, you know, found all of this interesting and said, well, you know, how much chemotherapy can we give and how effective is it? So if we're going to do the surgery and then throw in some chemotherapy, how big of a tumor can I leave behind in order for it to actually work? And so this was a study that was done and published years ago in the 1970s, essentially looking at all of these different types of agents using HIPEC and seeing exactly how deep they can penetrate. So that's commonly a question that patients will say, when you're putting the chemotherapy in there, what is it going to do? Is my hair going to fall out? Am I going to feel sick? Am I going to have nausea? You know, all the things you hear about chemotherapy. And the reality is it doesn't do that because it just doesn't penetrate that deep, right? It's the intent of the chemo wash in the belly is to kill anything that we cannot see. And as much as we'd like to believe that we can see and we've taken out everything, I think we as surgeons are fooling ourselves if we think we're that that perfect. And so this is kind of the fail safe. That's why you get the 1.5 hours of perfusion, so that if there is a cell that's left behind or anything else, this will hopefully kill it. And typically we use mitomycin C, and some studies will say that it penetrates about 3 millimeters, others will say 2. So we like to believe that it penetrates at least 2 to 3 millimeters in depth. And typically we'll only do this after everything has been removed. So the thought again was that intraperitoneal chemotherapy is designed to maximize the chemotherapeutic dose, meaning because it's not getting absorbed through your systemic circulation, through the blood, the way chemotherapy typically does, we can give you mega doses of chemotherapy without you actually absorbing it and it having an effect on your other organs. So it minimizes systemic toxicity, which is different, right? If we were giving you the same dose of mitomycin IV, which we don't do, it would have to be a much smaller dose. So we give you about 10 times as much intraperitoneally than we can give you through the intravenously. What about the hyperthermia? Why do we have to heat it? Or we just, do we enjoy making, boiling organs and things of that variety? No. So what the heat does is it increases the metabolic rate. Right. So you can imagine if you're working out, you get hot, you notice that you just start to sweat and all these other things happen. Your heart rate goes up, your metabolic rate goes up, you start to burn things off. The increased metabolic rate increases the generation of reactive oxygen species. That's why we always say, make sure you're well hydrated, make sure you're taking deep breaths, et cetera, et cetera. These reactive oxygen species cause protein damage, right? So that's why if you're training for a marathon or if you're working out, you kind of have to ease into it. You can't all of a sudden go out and run 15 miles because you're going to have way too much protein damage. It hurts your muscles. It does all sorts of crazy things. But in a controlled fashion, we know that if we can increase your metabolic rate, increase these reactive oxygen species, basically increase protein damage, all of those things basically cause protein damage at the nuclear level. They inhibit cell proliferation. That means fewer cells are dividing and growing. And then it actually damages the membrane. So like each cell has this surrounding pocket and all sorts of things can go wrong. Ultimately, that leads to cell death, which is what we want for the tumors, right? Now, again, keep in mind that the rate of penetration, it's not like by putting this in, we're killing your liver because all of this is happening. This thing only penetrates 2 to 3 millimeters deep. So it's really all at the surface level. So this all may sound scary when you're saying, why are you telling me that heat kills things? And then you're, heating me up to 41 degrees Celsius. Why is all that, how is that good? Well, again, this is fairly low heat dose in combination with chemotherapy that only penetrates a few millimeters. And so that's why the two of them work in concert with one another. In the 1970s, Dr. Spratt, who was, I think, at the University of Indiana, he actually figured out the first system for delivering this heated anything. It wasn't necessarily heated chemotherapy, but heated fluid into the abdominal cavity. And it was it was Louisville. The first patient was actually treated in 1979. And this was someone who had heard about Dr. Spratt's system that he was essentially studying by looking at its mechanisms in dogs, unfortunately, which makes me sad. But he read about it and said, well, someone told me, he was 29. He said, I have this thing called appendiceal cancer and they can't cut it all out, but you have this system that can deliver heated fluid in there. Is it possible that, you could cut some of this stuff out and treat it? And so they talked about how this was obviously not standard of care. We didn't know exactly what was happening, but it made a little bit of sense. And so Dr. Spratt actually treated the first patient in 1979 with some success. And then it was in the 1990s that, Sugar Baker, which some of you mentioned, you've been operated on by, so that's fantastic, really came up with the concept of cytoreduction in HIPEC. So the cytoreduction piece is basically the part where we remove all the tumors, and we'll talk about what that means. And then the HIPEC is essentially the chemo wash. This kind of demonstrates an image, and usually the catheters go in through the same incision. We don't make separate incisions for the catheters, but a lot of patients will have this done via an open procedure. And essentially we have catheters that go in that deliver chemotherapy and pull it back out. So this is kind of what that looks like. And then when Sugar Baker first published his results, he saw that, patients who had pseudomyxoma from a variety of different types of appendiceal cancer. And I think that's the most important thing. Not all cancers are the same. Not all appendix cancers are the same. Not all colon cancers are the same. They're all a little bit different. And I know as a patient, you hear the word cancer, and of course it's terrifying regardless of what type it is, but the treatment options for the different cancers vary a little bit. And the criteria for cytoreduction and HIPEC also vary based on the type of cancer that you may have. So I think someone asked the question of, performing a laparoscopic HIPEC versus open, and there's variations in all of it. So not everything I say applies necessarily to everyone and to every cancer subtype. And he essentially published and said that the 5-year survival rate, meaning at 5 years in the 385 patients that he had treated with CRS and HIPEC for appendiceal cancers, was 86%. And really before this, people would be dying from symptoms and bowel obstructions and everything that ensues because you have basically uncontrolled growth of tumor in the abdomen. They were typically dying within 2 to 3 years, despite the fact that it was a slow growing cancer, because by the time you presented with symptoms, you typically had a lot of disease in there, right? And it wasn't something that we're really able to pick up very well on CT scans and things of that variety. So what about patient selection? How do we choose? How do I, as a physician, and how do my colleagues, how do we choose patients who are eligible? So I think the basic tenet of surgical oncology in general, something that Blake Cady said, and he is a surgical oncologist who's since retired, but this is something we try to teach our trainees. So biology is king, meaning the tumor type that you have, right, is kind of the most important thing in terms of how we choose to manage it. Selection is queen, right? So when we talk about survival rates and recurrence rates and things of that variety, patients may all have the same type of biology, but not everyone will have the same outcome. There still might be slight differences within the biologic variant of the cancer type that you have. And this is really for us as the surgeons. The technical maneuvers are the prince and princess. And if I need to explain that further, essentially, occasionally the prince and princess, so if I consider myself a princess, try to usurp the throne, sometimes with temporary apparent victories, usually to no long-term avail. They almost always fail to overcome the powerful forces of the king and queen. So as a surgeon, I think the most important thing that we can do as surgical oncologists is, certainly be honest with our patients. And if there is a tumor type that really has poor prognostic potential, the question I frequently is, well, can we do surgery? Yes. And yeah, I can do a lot of things. That doesn't necessarily mean it's the right thing to do or that it's actually going to help you. And so that's kind of where this is important. We have to recognize that for certain cancer subtypes, chemotherapy might be more effective. Debulking surgery may sometimes fit in. A HIPEC may fit in. And it depends because there's a lot of variation between the tumor type and your particular tumor type. Your cancer is not exactly the same as everyone else's, but that requires that we kind of have a very real discussion about the risks and benefits and potential outcomes that could apply to you. So back to the patient selection. So again, histology of the primary tumor. This is that biology is king piece and the selection piece. The patient's overall health, good performance status. So, if I have a patient like Paul who walks in and tells me, hey, I'm umpiring X number of softball games, and how long do I have to take off from being a referee for the 300 basketball games he refs a year, and I know that he's physically fit and in excellent condition, I'm not so worried about his performance status, right? But conversely, if I have someone comes in who's, at baseline had different cardiac issues, is wheelchair bound, has poor respiratory status, sometimes these procedures can be a marathon, right? And so if you already have poor functional status, then that's something that we really have to discuss with the patient and the potential risks of the operation. And if you look at this chart on the right, you could see that these are for patients who had different types of HIPEC procedures. And ECOG is something that we use to kind of qualify performance status. So like ECOG of 0 or 1, that's kind of where Paul would fit. He's like a 0+. So you could see that for patients like him, you have surgery and we expect your survival to be great because you don't really have any other major comorbid conditions that would potentially lead to complications post-operatively during the recovery period, et cetera, et cetera. An ECOG 2 is someone who's, not healthier, and this should be an ECOG of 3. So that was kind of that person who's had the multiple heart attacks, is wheelchair bound, is, oxygen dependent. And you can see that the survival is significantly less for those patients. So when I'm saying your survival is X, I need to be careful depending on the overall health of the patient. And the reality is that certain patients may succumb to other issues we can't necessarily control. So patients' overall health is important. And then there's 3 critical criteria realistically, especially for appendiceal malignancies. So the tumor should be limited to the peritoneal surfaces, right? What this means is I shouldn't necessarily be seeing 50 tumors in the liver within it, right? A majority of what I'm planning on debulking should be extra with outside of the organs, not inside the organs. You should have limited visceral metastases. So again, this means if you do have liver metastases, maybe I should see 3 to 4 of them. So there's different numbers in terms of saying, the outcomes are significantly better for patients who have 3 or fewer metastases into the liver from, let's say, we're talking about a patient with colorectal cancer, with pseudomyxoma, with peritoneal carcinomatosis. We don't want to undertake operations that I think are heroic with no significant benefit to the patient, and then no extra abdominal metastases. So sometimes we'll see patients who also have metastatic disease to the lung or to the brain or to the spinal column and things of that variety. Again, doesn't really apply to appendiceal mucinous tumors, but it can apply to goblet cell adenocarcinoma of the appendix with signet ring features and things of that variety. So we kind of want to keep everything within the abdomen. And then the goal is always to completely cytoreduce the peritoneal disease, meaning we want to be able to get everything out of the abdominal cavity. If I tell you, hey, I think I can get half of it out, I'm not really doing you a favor. Again, this is because a majority of you have appendix cancers. Just to kind of put it into perspective, the annual US incidence of appendix cancers is less than 1,800. That's for all comers, right? Compared to colorectal cancer, which is 150,000, right? Very, very different. So these are rare tumors. And a lot of people say, oh, I read about that, or I'm not really sure. I think you can do this thing called a HIPEC. Don't really know how it works, et cetera, et cetera. So it's really important as a patient that you, certainly get as many opinions as you need in order to feel confident that you're being treated by someone who has seen this before, knows exactly what they're doing, and can kind of give you the best information that's available to date. A majority of, again, if you look at this, a majority of appendix cancers are mucinous, right? As compared to colon, only 15% of colon cancers are mucinous. So a majority of our appendix cancer patients have mucinous deposits, whether they're within the appendix or outside. And a majority of them are well differentiated. What does this mean? So when we look at the pathology report, well differentiated means it looks like I can tell where this stuff actually came from. And that means that they look more organized and discrete on pathology than something that's poorly differentiated. Something that's well differentiated indicates that it's actually slower growing and less aggressive. So well differentiated is better than poorly differentiated. And then PSM, essentially peritoneal surface malignancy at onset of disease. A lot of patients with appendix cancer will actually have peritoneal surface disease at the time of diagnosis. So it's not uncommon. Whereas colon cancers, it's only about 10% and there's particular mutations. And minimally invasive does not mean the type of procedure that we do, but it means that they are typically not aggressive in the sense that they don't metastasize to other organs. They don't metastasize into the lymph nodes. They're locally aggressive, but they're not invasive to the point where they're able to get into the different cells and kind of take over, right? They'll push things around and they'll stick to things, but they, we can get them out. And then if you look at potential surgical cases, out of the 150,000 patients with colon cancer, only a small proportion are actually potential surgical cases, whereas with the appendix, a large majority are actually surgically debulkable. And that's key. And that's why it's important to make sure that you're seeing someone who does this. So how do we as surgeons kind of communicate in terms of the disease burden within a patient? We go in there and we basically break your abdomen into these 9 quadrants, from the right upper quadrant down to the left lower quadrant. And then we take your intestine. So this thing is your stomach. And then you have your duodenum, the first portion of the intestine. And then you have essentially your jejunum, up until about here, and then you have something called your ileum, and then this attaches to your colon, and your appendix hypothetically would be sitting right here. So we essentially have these 13 regions, and at the time of surgery, we go in and we assign each region a score. And how do we assign a score? So essentially, if you have no tumor visualized in that particular region, you get a lesion size score of 0. If you have tumor up to 0.5 centimeter, it's a score of 1. Up to 5 centimeters, it's a 2, and then more than 5 centimeters or a confluence, meaning if I see tons and tons of little dots that I think if I added all those dots up together, they would add up to 5 centimeters, and I give you a score of 3. And why that's important is, again, not necessarily for mucinous appendiceal cancers, but we do have some data in looking at patients saying, okay, realistically, as amazing as I think I might be as a surgeon, realistically, at what number am I no longer providing a benefit to the patient? For pseudomyxoma of the low-grade variety, there is no cutoff, right? So you could be a 3 all around, and typically we should be able to do the operation. The area where we sometimes get limited is for some patients who have long-standing disease. If the small bowel is kind of entirely encased, and you can imagine that these deposits can either sit on the part where you see these blood vessels, the mesentery, or they could sit directly on the bowel, right? And no matter how good my intentions might be and how well I think I may be able to clear every last tumor off the small intestine, sometimes that's just not entirely feasible. Sometimes the tumor's been sitting there so long that this whole thing is basically significantly foreshortened. And so this is typically the most common limiting factor, even if you have very limited disease in other parts, because we can take out your colon, we can debulk a majority of the liver, we could take out your spleen, we could do, we can clear out your pelvis typically, but the small bowel, you can't live without it. You need about 190 centimeters to actually be able to function and eat and get nutrients and things of that variety. So that's usually the biggest limiting factor. But this is how we calculate a peritoneal carcinomatosis index. And then after the surgery, we like to essentially calculate the completeness of cytoreduction score. And so what this means is, ideally, we're always aiming for a 0, meaning I can't actually see anything left. And that's the most common question I get. Patients will say, did you get everything? And I will answer, I got everything that I could see, because I believe in myself, but I can't imagine that there's no cell left behind, right? So CC1 means that we left some disease that might be about 0.25 centimeters, right? Typically that you could see, but that might be something, again, if the entire small bowel is engulfed by tumor, and I know that I've had to leave some areas behind because I really can't take any more bowel, then we would give you a CC score of 1. Both a CC0 and a CC1 are considered complete cytoreductive surgeries. And the thought here is that we talked about the penetration of the chemotherapy should be about 2 to 3 millimeters. So the thought is that even if you've left this much disease behind, the chemotherapy should kill whatever is left. Once you get past that point, if you leave things behind that are a quarter of a centimeter to 2.5 centimeters or bigger than 2.5 centimeters, these are considered incomplete cytoreductions. Okay, so you can still do the HIPEC. You can still hope that it'll work, but it does not necessarily mean that we've cleared all of your disease. So this is important when we're talking about recurrence rates. And when I said we use this peritoneal carcinomatosis index to predict how frequently we can get to a CC0 or 1. Okay, so there is data for different, like colon cancers and gastric cancers. There's data saying, you know what, patients with a PCI greater than X don't seem to do well because of the following reason. Again, not applicable to mucinous appendiceal cancers, can be applicable to goblet cell adenocarcinoma depending on the degree of disease and the distribution of disease. So peritoneal surface oncology group, which you may have heard of, which is something that was started by Dr. Sugarbaker and is essentially an international society that provides the physicians with numerous guidelines. Identified some time ago 8 factors that were predictive of a complete cytoreduction. The ECOG, and that's because the ECOG, again, we talked, this was how healthy the patient is coming in. You might think, why is that important? Well, because you can imagine if we're doing a 12, 16, 18, 22 hour operation, and the patient is not stable in the operating room for the duration of that procedure, we can't keep operating, right? So if all of a sudden it's too much stress on your heart and we have to stop, well, we've only completed as much as we've completed. So that's where the ECOG comes in. No extra abdominal disease, right? Because this operation is primarily in the abdomen. So if you have extra abdominal disease, we're not necessarily helping you. Liver metastases, we kind of talked about, there's some hard and fast rules in terms of how successful we think we could be. And patients who have 3 or fewer hepatic metastases typically do better. The reason for the 3 is not so much, it's not so much a number, it's the degree of debulking you have to do within the liver and the rate of complications that can arise depending on how big of a hepatic resection you may or may not have to do. So if we're taking out half of your liver, like the big part, the right half of your liver, that's 70% of your liver gone. That's a pretty big thing to recover from. And it's not something that you necessarily want to add a 10 to 12 hour debulking in HIPEC to. Those patients tend to do worse. No evidence of biliary obstruction and no evidence of ureteral obstruction. Why? Typically, because like we said, these things are pushers, but it's soft, right? So typically it shouldn't push so hard that it's causing a blockage. So if on CT scan and things of that variety, we're able to see that your bile ducts are blocked and that your ureters are blocked, that typically means that there's something more invasive or more aggressive going on. And in order to clear that disease, we have to be more aggressive or invasive, which requires a bigger operation, portending potentially less success. Small volume disease in the gastrohepatic ligament. This is where essentially there's a ligament where there's vessels that go between the liver and the stomach. And small volume disease there is important because in that ligament, there's some really important blood vessels. And if there's a lot of disease and it's invasive and it's kind of growing into everything, the ability to clear that is significantly less. We talked about this one, limited small bowel and mesenteric involvement. I kind of explained why that's important. And then no evidence of intestinal obstruction. So sometimes when we do scans, we're able to see that you have an intestinal blockage, and sometimes that's why you may be having abdominal pain or discomfort, inability to eat. But when you have multiple points of obstruction, typically what that means is that you have invasive disease in multiple points of the small intestine. And this kind of brings us back to this point of limited small bowel disease. So it's a different way of saying the same thing. And these are very broad guidelines, not necessarily for appendix only, but for any patients who may be undergoing any type of cytoreductive procedure. So we talked briefly about the different types of peritoneal surface malignancies. Primary peritoneal surface malignancies, meaning they arise from the peritoneum. These are some of them, and a majority of them are malignant and fairly aggressive. DMPM is one of them, and this is a little bit older classification. There are newer ones. And then there's peritoneal surface malignancies that arise from secondary origins, right? So colon cancers that metastasize, gastric cancers, ovarian cancers. This term that you may be familiar with, peritoneal mucinous adenocarcinoma. So pseudomyxoma from mucinous adenocarcinoma of the appendix. This would be your goblet cell appendix cancers, or if you had an adenocarcinoma of the appendix with peritoneal dissemination, it's considered a PMCA, which is more aggressive than this thing called a DPAM or a PMP. It gets really confusing with all the terminology we have, so just kind of ignore me, but recognize that there's differences. But the DPAM and the PMPs are essentially pseudomyxoma from low-grade appendiceal mucinous tumors of the appendix, and these, again, behave differently. And then this is the most recent SOGI terminology, which is way too much for us, I think, at this point. But basically what I try to explain is there's a few different things. We have lamins, which are low-grade appendiceal mucinous neoplasms. There's Hammonds, which are high-grade appendiceal mucinous neoplasms. And both of these are, we keep saying non-invasive. So then when I say non-invasive, the patient says, well, then I don't have cancer. And I'm like, no, you still have a type of cancer. It's not invasive in the sense that it can't spread into different organs in your lymph nodes, but it locally is invasive, right? But it is a type of cancer. And then you have your adenocarcinoma, which has a different pattern of invasion, and that can get into lymph nodes, other organs. It's the kind that will kind of grow the blood vessels that we talked about after a certain range. It's not just this mucinous film that kind of sits everywhere. And then PMP is defined in different ways, which again, we don't need to get into, but essentially there's low grade features, high grade features, and then signet ring cells, which is typically consistent with high grade histology, like your adenocarcinomas that may have goblet cell and signet ring features. All right. So the different indications, for the most part, pseudomyxoma, the DPAM and the PMCAs, almost all patients will be eligible for HIPEC, okay? The malignant appendix patients, most to a highly selected cohort will be eligible for cytoreduction and HIPEC, right? We can actually be pretty aggressive with the majority of our appendiceal neoplasms. The other types of cancers, you know, we have to be highly, highly selective, and sometimes we find that there's no benefit in really considering cytoreduction and HIPEC for these patients. So again, that comes into play when I'm seeing a patient who either has a sarcoma or a pancreatic malignancy. Well, they say, I had a friend who had an appendix cancer and they had this procedure and they took everything out and he's been alive for 23 years. And again, we have to go back to the fact that, okay, yes, these are not, they're not the same disease type. And that's something that's important, especially for you guys, is you have other people who probably reach out to you to make sure to educate them that things are different for different patients. This is, we've kind of already talked about this, so I'm not going to go into it, but essentially if you have a perforated appendix and pathology shows peritoneal metastases, depending on the type of cancer that you have, you're a candidate for cytoreduction and HIPEC. If you have intestinal type perforated appendix or a poorly differentiated appendix, again, these could be considerations, but usually in this purple box, we'll add systemic chemotherapy into the armamentarium of treatment because they behave differently. Technical aspects, this is where we're going to have some photos, so please avert your eyes if you can't stand them. But essentially, what does the procedure require? So frequently I will start with a diagnostic laparoscopy to assess a PCI score, again, for a majority of low-grade appendiceal mucinous neoplasms. This is less important, but I'm not going to touch upon it today because that's a whole separate talk. But imaging is not perfect. We don't have fantastic imaging to find low volume disease. So a lot of times the way to think of this is you're making kind of like a peanut butter and jelly sandwich, and you could put a lot of jelly or you could put a lot of little jelly. And if you were to take a picture of that peanut butter and jelly sandwich, you may not actually see the jelly if there's a really, really thin film, right? Similarly with these mucinous neoplasms, if there's a really thin film of jelly, no matter how I scan you, I will not see that film of jelly. There has to be enough there for me to see it. Similar to if I'm looking at a tumor in the liver, if it's under a centimeter, it may be missed. Similar to why patients ask me why they need colonoscopies. Can't they just get a scan? No, because we can't actually see things that are small, and colonoscopies are preventive of the development of cancer. So we want to pick up things when they're really small. If I see them when it's big enough, then that means it's too big. So sometimes that's why the diagnostic laparoscopy helps, because you actually are able to have eyes into the abdominal cavity. That's usually, sometimes it's done at the initiation of surgery. Sometimes it's done as an entirely separate procedure for patients who have been sent to us and someone said, oh, I went in there and I saw a bunch of mucin, and then I get no other useful information from the operative report, and I get a CT scan, I don't really see anything. And then I'm like, well, I don't actually know what they saw. So in that patient, we may do a diagnostic laparoscopy to assess how much disease there is. And then we typically will do a laparotomy and a tumor debulking. As someone asked, is there a role for minimally invasive HIPEC and robotic HIPEC? Yes, in highly selected patients, there is a role. But if you remember back to kind of my first picture where I was showing you that disease is in the pelvis and all the way up in the upper abdomen, trying to do that robotically would basically result in me making you look like Swiss cheese by the numbers of holes that I have to put in order to get to all those different sites. And if you add all those little holes up, you end up getting the same thing as a big incision. So we don't think the recovery is that much better. But if all of your disease was located just in the pelvis, or just in the right lower quadrant, or just in the left lower quadrant, then those are cases that may be amenable to this type of debulking and disease. So we do the laparotomy, we do the tumor debulking, we put in these cannulas that are going to deliver the chemotherapy and basically pull it back out. Then we close your abdomen. In the US, a majority of us will do it via closed technique, meaning we don't leave your abdomen open while the fluids is sloshing around in there. And that's mostly to, for purposes of your safety and the safety of other individuals in the operating room. And then we circulate and heat the fluid. So we add the chemotherapy once the temperature of the fluid reaches about 41 degrees. And then depending on the drug we're using, you'll get perfused for 30 to 120 minutes. With the mitomycin, typically it's 90 minutes of mitomycin C perfusion for our appendiceal malignancies. For some different cancers, we will simultaneously get systemic chemotherapy through an IV. But for a majority of our appendix mucinous tumors, we don't actually do that. And then basically we kind of already talked about this. We are looking constantly at the flow rate of how quickly stuff is flowing in and out of your abdomen. And we typically want the goal flow rate to be between 600 to 1.5 mLs per minute. We don't want it to be too fast because we actually want the chemotherapy to sit there and do something. But at the same time, we want to make sure that it's flowing. And while this is happening, we're kind of gently agitating your abdomen. Because if you think of a stream or a river, fluid kind of seems to flow in the exact same direction. So by kind of pushing on your abdomen and gently agitating it, we're allowing the circulation to kind of hit all the different parts of your abdominal cavity. And typically there's about 3 liters of fluid in the abdomen, which is exactly the mean of 2 to 4, but it depends. You know, some of my patients are, 6'6" and have a lot more space in their abdomen. And if I put in 2 liters, it certainly wouldn't hit every surface. And then I have other people who are 5'3", and if I put in 4 liters, they would explode. So there's some variation there, but there's metrics that we use. Here are the pictures. So these are some representative pictures from diagnostic laparoscopy, different patients, and you can kind of see it looks like mucus. The underlying pink stuff in this case up here in the upper left is peritoneum, and then you can see that there's kind of this thin film that you can appreciate, and then a thicker area. Similarly here, this is small bowel. The yellowish stuff is actually the mesentery. So this is an example of someone in whom we were actually able to do the site reduction because this stuff peels off really easily. But you can imagine if this entire small intestine was seeded with disease that I can't peel off, I have to be able to either cut out this part of the intestine and know that you have enough other healthy intestine where we could do the procedure or not. And then this is more of that disease, but you can kind of appreciate when we kind of use some other instruments, this peels off nicely, again, suggesting that it's not invasive in the way that some of the other cancers can be. It's not growing into anything, it's just kind of coating everything. And then this is another patient, again, with similar type disease. The blood that you're seeing is because I scraped stuff to get tissue biopsies. And this is on the liver. So this is actually liver here, this whole thing in the middle. And you can see that there's just a little bit of disease. This is kind of a big wad of mucus that's sitting on the liver capsule that can get peeled off. And so this is in the abdomen when we finally do the operation. This is the mucus, right? And you just collect it, you can suction it out and put it in a bowl. This is what the abdominal cavity looks like. You could see that it's kind of irregular all throughout. This is something called the omentum. But then if you look at the small bowel in this patient, it looks all clean, right? So there's a lot of disease coming up to the small bowel, not really involving the mesentery, maybe just a little bit here. But we can get rid of all of this, and we can get rid of all of this, and essentially clearing all of the disease. Essentially, the procedure involves us kind of peeling off this very, very thin peritoneal layer that has all of the mucus adherent to it. This is kind of that significant area that I was talking about with all the vessels up against the diaphragm. Sometimes when we're peeling things off the diaphragm can be really thin in certain patients. And so sometimes we inadvertently can enter the chest cavity. You may have a chest tube. These are all things we certainly talk about, but that's the reality of it. And then in the pelvis, these panels on the bottom, this particular patient is a female who had a hysterectomy. So there's the vaginal cuff there. We actually really like the uterus because it actually protects the pelvis from getting a lot of these tumor deposits. So a lot of times in females, it's the pelvis is not as involved as it might be in a male because the uterus has actually protected the pelvic sidewall and has kind of garnered picking up a lot of some of that disease. And so sometimes we could do a hysterectomy and clear a lot of the pelvic disease. We don't really have that option. And then certainly we've had patients who, if you have an inguinal hernia, you can have that same mucin kind of go into the inguinal canal. And that's something that we also have to clear. Here, this is a big wad of tumor that essentially has thick capsules, right? This looks like I'm taking out an organ, but I'm not. This is just mucinous tumor. So essentially there's formulation of a capsule around the different segments of mucus. And you could see you have the stuff on top, right, which is easy to peel off, but then you can have things like this, which are pushing and causing problems. And that's why some people may have abdominal pain, discomfort, because it almost looks like there's a whole separate entity that's growing, that's kind of invasive. This is that thin layer of peritoneum that we're peeling above the liver. And then you can see here, you can kind of see all the muscle fibers. We move the liver out of the way. And you can no longer see that really kind of the pink appearing peritoneum. But you see that all of the disease is clear. These are the patients that you had seen previously. And then essentially we put in our catheters, we close the abdomen. This is one of our residents after a long HIPEC, and you can see that they're overjoyed to be there, gently agitating the abdomen, but it's nice because we get to sit down. And so the perfusion happens for about 90 minutes. And then it's your job, then it's on to recovery. So building your team, this is, I think, of critical importance. You want a team that looks like this. And typically you should be kind of, to a degree, the captain of your team, but your team may involve a number of different people depending on the cancer that you're dealing with and ultimately other issues that you may have. So typically you'll have a surgeon. You may or may not have a medical oncologist who's involved. Typically we certainly do, though they kind of play a background role because I can't write chemotherapy orders, they do. So despite the fact that you may have never met your medical oncologist, there is typically someone involved. And in certain subtypes of cancer, like appendiceal adenocarcinomas, a medical oncologist is almost always involved because it usually involves either at least a discussion about the role of systemic chemotherapy for those patients. Then your primary care physician, right? I mean, you may have underlying diabetes or high blood pressure or cholesterol issues. So we want to make sure that that person is involved and knows what you're going through, because there's going to be changes that happen with the surgery and things of that variety that may require that they're involved. Sometimes we need other services. Like if for whatever reason I've decided that I'm going to take out your ureter because there's a short segment that I just can't clear the tumor off of, but if I can just get that segment, we're going to be, free of disease, then I might involve a urologist in order to kind of put things back together. Sometimes we may involve gynecology and oncology. Typically gynecology and oncology will involve us for their ovarian subtypes. And then aftercare. I think this is kind of what Paul had mentioned in the introduction of it. It takes a village, and I think it really does. This certainly takes a physical toll on you, but I think it also takes an emotional toll as well. And so it's important to kind of have a core group of people who, a big team. You need a team. Shared decision-making, I think, is of critical importance. So if you've never heard of it, I'm sorry, but you should have. But essentially the thought is that shared decision-making is a process in which clinicians and patients will work together to make decisions and select test treatments and care plans that will relate to expected outcomes and patient preferences. Traditionally, it's kind of been like you go to your doctor and they tell you what you do, and then you say, okay, I don't know why the doctor always has to be a guy, but it's okay. We're trying to change that. And then currently we kind of have a more bidirectional patient-centered view where, my job is to educate, empower you, make you feel like I'm your partner, and then you can come back to me and say, well, that doesn't make any sense, and I think that's ridiculous, and I either don't understand it or I don't want to do it. And then, we can kind of go back and forth, and that certainly makes more sense, I think, especially in the treatment of cancer. And there's been studies that have been done that say that patients whose providers actually listen to them, elicit goals and concerns, and explain all options, have patients who are 3 to 5 times more satisfied with their providers. So I think it's something that we as doctors have to do a better job of doing. And it, I think, ultimately results in better quality decision-making. So my job typically is to give you easily understandable information regarding your diagnosis. You guys can give me feedback if I did that to a degree today, and then provide you with a list of options. A lot of times we have options. Sometimes we only have one option. So, it's not always perfect, but the goal is to say, this is what we can and can't do, and this is what makes sense in my opinion. And then to provide the pros and cons of each option and specifically how it relates to you. And then ultimately really to listen to what you have to say. What's important for you, because sometimes you come in and we say, hey, you have cancer, and then that's it. We get nothing else because you actually don't hear 90% of what's being said to you after that point. And sometimes that's okay. Sometimes you just need to say, you know what, I just need to process, and we need to have this visit again or I want to come back with my partner or my daughter, whomever it is, so that you have essentially someone else present, because this was an unanticipated visit to a degree. But your job is to tell me of your symptoms as best you can. And I know sometimes that's difficult because sometimes there aren't any. Your lifestyle, what's important to you, right? I'm a very active person who loves my job, and, you know, timing of life and things of that variety. What are your goals, right? And in cancer treatment, we have patients who have all sorts of different goals. Some are to live forever. Others are to see their grandchild being born in 2 months, right? And so whatever it is that we're planning on doing has to fit into whatever that goal is. Treatment preferences, and then past experiences. And I can't stress this enough, because sometimes I'll have a patient who has an appendiceal mucinous neoplasm, come in, I tell you have cancer, and then that's it. That's the only thing they've heard, and the only thing they could think of is their, you know, aunt whom they had to care for with a horrific cancer, who was in and out of the hospital, who had chemotherapy and lost their will to live. And that's all they're hearing after I've said, this is a cancer. They hear nothing else about, hey, you're going to be here in 10, 20, 30 years, and it's going to be a rough couple months, but, you know, ultimately the prognosis is very different than what your aunt or uncle may have had. So with that, it's kind of important to be open-minded. And then for some cancer types, we know that, you know, no matter what we do, sometimes cancers come back. Sometimes you have to have multiple procedures. Sometimes they can mutate and become more aggressive. And so you kind of have to be open-minded about exploring different treatment options and trying to gain, you know, consistent information. But ultimately, I think you have to trust in the people who are helping to treat you, and you have to feel comfortable and empowered to add your own perspective. Because if it's, again, this unidirectional pattern of I'm telling you what to do, that's just not going to work long term. So if that means you need to get 100 opinions, I say that with some lightness, but if you need to see more people because you don't feel comfortable with the first or second person you've seen, then that's okay. What about after your diagnosis? Some questions you can ask your physician, you know, how many of these have you done? I think is an important question, but I don't think that that's the most critical necessarily unless they answer one. But, you know, everyone has to have a first. It's a question of really how many of these have you seen, right? Because if someone is fresh out of fellowship, let's say, they may have done 100 of these in fellowship and in training, but you might be their first patient, right? So again, how many have you seen? It is sometimes a better question than how many of these have you personally performed. What is a tumor board? And you want to ask if your physician participates in a tumor board. So a tumor board is essentially a multidisciplinary team where we essentially come together and we look back at all of the path results, look at all the imaging with an imaging specialist, a pathologist, a medical oncologist, additional surgeons, and ultimately determine the best treatment plan for that patient. So for someone with an appendiceal adenocarcinoma with low volume disease, it's an important conversation to have, because I might say, well, I think we should give chemotherapy first. And the medical oncologist might say, well, there's only 2 or 3 dots of disease. And if there's no disease in the lymph nodes, then I would give a lighter version of chemotherapy. So getting that pathologic information is important to me, and vice versa. So we have this kind of open conversation. And I think more heads are always better than one. So that's sometimes helpful. And a majority of major institutions do have a tumor board where we kind of discuss all of these things and then review your post-operative imaging and post-operative care. You should make sure to follow up after you've met all the appropriate members of the team and create the best treatment plan for you. So timing of surgery, if that's involved, timing of chemotherapy, if that's involved. As I mentioned, don't be afraid to seek another opinion. And then really you have to kind of be satisfied and trust your team, because that, you know, you're trusting them with your life. So it's important that you feel comfortable with these people. What about future directions for peritoneal disease? So what we're currently looking at is new drugs or new drug combinations. Mitomycin C works pretty well for pseudomyxoma of the low-grade variant. So, you know, if something works, there's really no need to try to change it. The only question that we sometimes have is there a shorter duration of therapy that we can give with the same benefit? But as I mentioned, this is a difficult thing to do, because that would mean you would have to randomize patients, right? I would have to have 2 patients with the same disease type and say, okay, I'm going to give one of you this new therapy and I'm going to give the other one of you this old therapy that I know works, but we want to see if the new therapy works. And you might say, well, where's the equipoise? How do we know? If that thing isn't working, why would anyone sign up for that trial? And that's where we have some of that difficulty. Intensification of the bidirectional approach, as I mentioned, the bidirectional approach is that thing I was talking about where you're getting the intraperitoneal chemo, and then we're giving you IV chemo simultaneously. We do that sometimes for our colorectal adenocarcinomas and some appendiceal adenocarcinomas. Intensification means, do we want to give you more drugs through the IV? That's an option. And then drug delivery systems. This is kind of where a lot of work is being done in terms of how can we basically put in the chemotherapy in different ways that will either allow for shorter duration of surgery under anesthesia, right? Could we put something in there that kind of has like this delayed release with the same efficacy of tumor penetration and same uptake? And so we're working on all sorts of things like microspheres, micelles, nanoparticles, and liposomes. I think I was told that someone had spoken to you guys about Bromac previously. That's not this, but that's something that's really supposed to break down the mucus. And it's not, available currently in the US. And if we ever get it, we would be excited to try it. But that kind of, that works for some of the mucus subtypes that, as I mentioned to you, you saw that picture of me taking out the big bulky thing. The thought is that it would break some of that up and allow it to kind of scoop up easily. But again, that's not these drug delivery systems. That's just something that is supposed to soften the mucinous deposits. And then organoids, again, we're not really doing this in the PMP low-grade appendiceal mucinous neoplasm area, but for patients with colon cancer or gastric cancer, things of that variety, it's taking the patient's actual tumor and growing it into essentially a small organoid and then trying to treat it with different types of chemotherapy, essentially in a bath, and trying to see how that would work. Obviously, that is not easy to do. Organoids are not necessarily easy to develop unless you have something very cellular, and these mucinous things are typically not cellular, which is why they're not as invasive. So it's a different arena here. And then alternative chemotherapy agents we talked about. And then PIPAC is something that you guys may have heard of. There's a few institutions in the US currently doing PIPAC, and it's something that we have been using in Europe. Essentially, it's pressurized intraperitoneal aerosol chemotherapy. And currently it's being used for patients who are not candidates for cytoreduction, meaning you have to have disease that we don't think we can debulk. And then the thought is that we essentially introduce chemotherapy, kind of like if you think of a snow globe, it's basically chemotherapy, aerosolized, not liquid. We blow up your belly with CO2. Put in a couple catheters, and then we have this chemotherapy solution via a high pressure injector that ultimately goes into the abdomen, and then it coats all the visualized surfaces. So what's different between the PIPAC and the HIPAC is liquid, right? So all these other surfaces that are not covered by green or blue, I'm sorry, would technically get coated with the fluid because we've opened up all those spaces. In the PIPAC, we're not really debulking anything. We're just putting in this chemo and hoping that by sitting on the tumor area, that will diminish some of the tumor bulk. And what PIPAC with cisplatin and doxorubicin is something that we've used for hepatopancreaticobiliary malignancies. So those are your bile duct cancers, pancreatic cancers, things of that variety. Is second line therapy, meaning you've tried something and it hasn't worked, and then we can consider it. Third line therapy in ovarian cancer, meaning we've tried multiple other things, 2 lines of therapy, and this hasn't worked. Some patients with peritoneal mesothelioma, and then for some patients who need control of their ascites, kind of like I had talked about that surgeon who was treating patients with palliative HIPEC for control of ascites. Similar concept, but this is something that could be done with a minimally invasive approach, and typically you can go home in a day. And then PIPAC with oxaliplatin is being used for colorectal cancer and some other peritoneal surface malignancies with high selection. And we think of appendiceal adenocarcinoma, especially with goblet cell features, it kind of fits into how we treat colorectal cancer in terms of the chemotherapy agents we use and some of the cutoffs. So that would be included there. So in conclusion, cytoreductive surgery essentially refers to the removal of all visible or macroscopic intra-abdominal tumor, and then HIPEC refers to the circulation of the heated dose of chemo within the peritoneal cavity. Ideally, we should be able to complete macroscopic resection, or a CC0, and in appropriate patients with primary peritoneal and appendiceal malignancies, the CRS and HIPEC is known to significantly improve survival and disease-free survival, meaning you don't have recurrence of your disease. And it's currently considered the standard of care in those malignancies. And hopefully we'll find additional ways to better serve our patients.
Dr. Gangi, that was so educational and informative. Oh my goodness, I think we learned so much. I think you probably saw the questions in the chat. So we'll take some questions. If you do have additional questions, please put them in the chat or raise your hand, and we'll try to get to as many as we can. We'll go with some of the advanced questions that we had first, and Dr. Gangi, I sent those to you.
Yeah. Try to find them.
Okay.
Yeah, Adele, I sent you this question, Dr. Gangi. One of the things that a lot of our patients deal with after the surgery is adhesions. And I wanted to see if there's anything a patient can do, or if there are new techniques for surgeons to use. I think one of our visiting surgeons mentioned there is some drug that can be used during surgery to help coat organs, but it doesn't seem to be in wide use. Could you address adhesions?
Yes, I don't like them.
Yeah, we hate them.
I don't like them, and it's very difficult to predict what they're going to do or which patients they're going to present in and how. Is there anything to do? I'm not sure what a previous physician may have mentioned, but we do have. It's basically like a thin membrane. It's a thin sheet it's kind of like a collagen product that should prevent essentially binding of the tissues to one another. The efficacy is questionable to a degree, not in the sense that it doesn't necessarily work, but it works in some patients and not in others. So we don't really have a good understanding of how to use it. The challenge with that is that, let's say you've had your operation and we're putting this in there and you have new connections of your intestine. We don't want to put an anti-binding agent on an area where you may have a new anastomosis, or where you may have some raw surface bleeding or things of that variety. So typically we won't use it if I've given someone an ostomy or something of that variety, I may put it immediately surrounding that area, so that if we're coming back for an operation in the immediate future, in the next couple, 6 to 8 weeks, then it might be useful. In addition to that, I would be certainly open to anything, but I have not yet heard of anything that's kind of ready for prime time in terms of preventing adhesive disease. I think for patients who, develop bowel obstructions downstream from what we predict to be recurrent adhesive issues, typically we'll just say, dietary modification and trying to either have clear liquids or low fiber diet for a period of time until resolution of those symptoms. And what you find is that a majority of patients ultimately learn better than you how to manage their own kind of post-surgical potential obstructive episodes that we relate to adhesion. So I don't have anything magical as of yet, but we're working on getting some fairy dust.
Thank you.
Right. Marav, would you like to ask your questions?
Hi, yes. So first of all, thank you so much.
Sure.
Thank you so much. So my question is, what about the post-CRS plus and the IPEX surgery regarding the treatment? What is the common treatment that you recommend after it? And in my case, I already gotten the 12 treatments of Folfox, and the pathology showed no response. So I'm wondering, what is the standard of post surgery?
Yeah, so I think the important thing again is to, why did you have the HIPEC? Not you specifically, but why you had the HIPEC will determine your ultimate post HIPEC follow-up and what you might require. So again, if you have an adenocarcinoma subtype of an appendiceal malignancy, sometimes that'll involve you getting systemic therapy. And typically for those patients, the follow-up is imaging every 3 to 6 months for the first 2 years. And in patients who have adenocarcinoma, and sometimes you have elevated tumor markers, some things called CEA, CA19-9, CA125, or things that your doctors may measure that may sometimes help us identify if you have recurrence or if you have response. the adenocarcinoma patients will frequently be treated with HIPEC if they were moderate or high grade, and if there was disease outside of the primary site alone. If full FOX therapy doesn't work, we also have the option of treating you with something called FOLFIRI. So the oxaliplatin in the full FOX is then changed into something known as irinotecan in the FOLFIRI, but the 5-FU and leucovorin are maintained in both regimens. And then typically if that doesn't work, sometimes you can rebiopsy the tumor and see if there's different mutations that may render you able to get treatment with immunotherapy or targeted therapies, both therapies that'll treat specific mutations in cancer. And then in a subset of patients, we can consider PIPAC depending on the degree of disease. We may consider, repeat cytoreduction. So there's certainly options, and I think it's difficult for me to answer exactly what would be applicable to your case, knowing very little about it. But those are typically the next steps.
Okay, and the next question is regarding the scans. Which scans do you recommend for monitoring in the mucinous case?
So I alternate between CTs and MRIs, and the challenge, the MRIs, they're sometimes more sensitive, but it depends on where the MRI is done and the MRI protocol. So not all scans are created equal, and you may have heard this depending on the number of years that you've been dealing with this. And if your physician says, I need you to get a scan at institution X because I just can't see anything when you're doing it locally, and then approval from insurance. So insurance is really hesitant on approving MRIs frequently, is the challenge that we've found. But I think a high quality multi-phase CT scan with thin cuts can sometimes be just as good as an appropriately done MRI. A poorly performed MRI is going to be more useless than a bad CT scan. So there's variation, and it depends on kind of access, insurance authorization, and things of that variety. But multi-phase CT or multi-phase MRI.
Dr. Gangi, are you doing PIPAC at Cedars Sinai?
No, City of Hope is in California. We're not.
Yeah.
Sarah, would you like to ask your question?
Thank you so much. And Dr. Gangi, that was so informative. I'm relatively new here. I was diagnosed with, just incidentally found a tumor in my appendiceal orifice, and with a routine colonoscopy. I'm relatively healthy, 60-year-old, and felt great going into it. So I had no symptoms whatsoever. I ended up with the path report showed a stage 4B goblet cell adenocarcinoma. I had like about 2.5 weeks later after diagnosis, I had the cytoreductive surgery and clear margins and no lymph node involvement, but I did have the spread, metastatic disease to the peritoneum. I'm about to start
Capecitabine.
Thank you. And oxaliplatin in 2 weeks. I'm going to get a port next week. Is because I'm voraciously reading like everything in the not quite as much online, but I'm looking at what other people say that have lived through this or are living through this.
Yeah.
And I see full FOX and FOLFIRI frequently. And so now I'm like, I mean, I'm calling from Connecticut.
It's okay.
We're not a big center, but we have a guy who trained at UPenn and brought HIPEC to us. And I think we have a pretty good cancer oncology service.
Yep.
And I'm sure you can't tell me what I should be starting in terms of.
No, I can actually, and I will. The Zelox is okay. So what you're getting is the capecitabine and oxaliplatin, which is equivalent to the full FOX. So there were studies that were done in colon cancer, and like I said, for adenocarcinoma of the appendix, we always go back to colon, just because I showed that slide about how much more common colon is. And if we wanted to do these trials in appendix only, we would never accrue enough numbers to give you any meaningful data. But Zelox, so that you don't have to say capecitabine, you can just call it Xeloda. Zelox is the equivalent of full FOX, and we found that there's no significant difference in terms of outcomes in patients who are treated with Zelox versus full FOX, unless you have very high grade tumors. And sometimes it's easier because you're able to just take the pill and then go in for just an infusion less frequently. The Xylota can give you diarrhea if you don't know that. That's the only thing to be mindful of. So if you're noticing that once you start that treatment, that you're having a lot of issues to the point where you can get dehydrated and things of that variety, that's something to mention to your oncologist. And so sometimes they then have to switch you to full FACS because the IV formulation doesn't have that same side effect profile.
Okay,
You're okay.
thank you.
Marav, did you have a follow-up question?
Yes, I just wanted to make sure that I understand correctly. Dr. Gangi, did you, in my case, it's the adenocarcinoma appendix cancer mucinous type. So if I heard you correctly, did you said that following post CRS and IPEC, no chemo is recommended? I'm sorry if
No,
I didn't.
I said chemo is typically recommended.
Okay,
Again,
so
I don't have your pathology report. I don't know if you're well differentiated, no nodes. I mean, there's a lot of criteria that we look at. So I'm speaking more generally, but typically for an adenocarcinoma, there's always a consideration for chemotherapy depending on those other factors.
oh, okay, but without any scans, I mean, just as adjuvant chemotherapy, if there is a lymph involved, so you recommend chemotherapy anyway and not wait for something to display on the CT scans.
If you have lymph node involvement, yes.
Okay, and the PCI, it's also what are the factors, just to understand that I didn't miss anything.
The factor for what? Chemotherapy?
Yeah, adjuvant chemotherapy after a HIPEC, successful HIPEC.
Nodal involvement, and if you had presence of disease in the peritoneal disease that was resected. So sometimes you have an appendiceal adenocarcinoma that's only in the appendix, right? That we took out, that's clear of margins, and everything else we removed during your cytoreduction is just mucus, acellular mucin, and you had negative nodes, and everything is very well differentiated. You may consider not doing chemotherapy in that patient. If everything that was taken out of you was consistent with adenocarcinoma and you had positive nodes, the PCI doesn't matter whether it was 1 or 100. It doesn't go to 100, but you get my point.
Okay, and thank you. And the FOLFIRI can use as adjuvant chemotherapy.
Correct.
Okay, thank you so much.
Sure.
Okay. Chris, did you have a question?
When the peritoneal stripping is done, does the peritoneum regrow? Like I'm thinking about repeat patients. So can you strip again the second time?
Yeah, so it's a great question. The peritoneum supposedly does regrow. I've only done a select number of repeat HIPECs in patients who have either had them done many, many years ago. And I think it's always very difficult to differentiate if it's a peritoneal layer or if it's a tumor layer, because the pathologist doesn't necessarily say, oh, this is a wholesaler, but it never looks the same as it originally did. So it always looks like there's a defect in that area. But I think there's a very, very thin film. The same way a scar, right? If you have a hole that kind of closes in, if you didn't have a perfect cut, and we've all had some kind of scrape, you could notice that area of skin looks a little different, but technically it's still skin. So, yeah.
Yeah, thank you.
Yeah, hi. First of all, thank you. That was really informative. And I'll say, I just had my HIPEC and CRS in March. And even though I learned all this before my surgery, seeing it and hearing it from you after going through it, it's like mind blowing to think that this is what we've all gone through. And you did a really good job of explaining things. So thank you. And my question is, I was taking some notes. I have my 3-month CAT scan coming up, and I'm assuming blood work also. I've kind of been trying not to think about it, but it's all next week. Do you have any advice on what I should be asking my doctors for? Because I do trust them, and I loved your slide on picking a team because I got a lot of opinions and it took a while for me to pick my team. But we never talked about the different numbers and everything that you had talked about. They've never reviewed that with me. Like, I don't know what my CC score is or PCI, and I've heard that in our group meetings every week, but I never really thought much about it. Because again, I've been trying to just not think about it, but is there anything specific you think I should be asking them? I trust them and I'm sure that they know, that I'm in good hands, but maybe for my own anxiety and knowledge to know what to look for.
Was it a low-grade appendiceal mucinous neoplasm that had perforated, or what was was that what it was?
Yeah, I should have said that. It was lamin. Yeah.
Okay. So I think in that respect, And I think in patients who are able to get cytoreduction and HIPEC, I think those numbers matter less. It's sometimes when you're told that you can't, or why, or, you know, some of the data behind why we're doing what we're doing. In the case of a perforated lamin, which I'm assuming is what you had, there's no cutoff for a PCI. So whether it was 5 or 39, we, you know, as long as it wasn't coding something that they couldn't remove, which it sounds like it wasn't, then the PCI number is irrelevant. And I'm sure at some point, either you or some member of your team asked, did you get everything? And if they said yes, then that essentially means that you had a CC0. So you've asked the questions, just not directly for any other.
Okay, that makes sense. Thank you. And they said that this scan then is basically just like to see the baseline.
Yeah,
Exactly right. That all makes sense then to you. So,
yeah,
okay,
100%.
All right, thank you.
Sure.
Alex, with all the medical disciplines that are out there, what prompted you to focus your interest in this particular type of disease?
My grandma had a sarcoma, and I kind of watched her go through that entire thing when I was a kid, and I was kind of fascinated with everything the body did. And then I decided medical school was too hard when I went to high school. And then I was going to be an archaeologist. And then I realized, no, everyone's already discovered everything there is to discover. So I have to redirect my interests, went to college, again, was kind of fascinated by biology. And then in medical school, you rotate through a bunch of different things. And I think the thing that drew me to oncology was that the patients actually made me want to do better and work harder. The resilience that the patients had and the impact that we were kind of able to have in working together as a team was something that was really kind of important to me. And as a surgeon, sometimes, you know, if I'm just doing gallbladders, you know, I see you after your gallbladder surgery and then I never see you again. But for most of our cancer patients, we see each other every so often. And to a degree, I think we become family, or at least I like to think of it that way. So that's important to me.
Great question. There are quite a few questions in the chat. One of the questions related to a situation where the patient's HIPEC was canceled due to kidney concerns. And so there were two questions in the chat. Is HIPEC a possibility in the future? And then is there a concern with the systemic chemo?
So I think that specific question for everyone was, you had a perforated appendix cancer. It was a 3.2 centimeter adenocarcinoma, moderately differentiated. And then his creatinine was 1.5. So the upper limit of normal for creatinine is about 1.2. But 1.5 is not actually awful, just so you know. And then he had his right hemicolectomy, but they didn't do the HIPEC secondary to his kidney concern. So my question to you was, was it just because the tumor was perforated that they did the HIPEC, or was it because they found additional disease?
It was just due to me locating him, and our primary sent us over to Dr. Kim at the Markey Center in Lexington, Kentucky. And we're going to do open the ascending colon. Sure. And he was going to do HIPEC at that time, but he backed off a little bit because of the creatinine.
Right, but did he see any disease in the abdomen when he did the right colon? No, right? So it was a belt and suspenders approach. They were just going to throw in the HIPEC because he had a perforated tumor.
Yes, ma'am.
So that's always, it's a difficult question, because our job really, I mean, we take an oath that says first do no harm. And in the setting of not seeing disease that's disseminated, and you're thinking if there could be some kidney toxicity and we put Mr. Blackburn into some kind of renal failure, then we haven't really done him a favor for disease that we're not actually seeing. So I think the narrative certainly changes. If there was disease that they were seeing, probably they would want to take that out and do the HIPEC. It's just a question of how aggressive you want to be prophylactically, right? Because the HIPEC, it sounds like, was prophylactic. So would he be a possible candidate in the future? Yes. The mitomycin C that we typically give does not have significant kidney toxicity, but it can, especially if you only have one. But I'm assuming that they're planning on following him with scans, and if anything comes back, he would still be a potential candidate.
Thank you, doctor. They're also considering chemo at this time, and he's not been having scans with contrast because of the kidney.
Yeah.
Will he need to have contrast in the future if symptoms occur?
They could do an MRI, which is less the contrast from the MRI is not toxic to the kidney. So that would be a good option. And then did he have, were his nodes positive or no?
Negative.
Okay. So really it's that how aggressive should we be for something that we presume could ultimately cause a problem. And I think it wouldn't necessarily be wrong to do chemotherapy as long as they go through all of the different options with you, but a moderately differentiated tumor with perforation, with negative lymph nodes, you're really right on the fence. There's no perfect answer. So as long as they're telling you these are the benefits and these are the risks, then that's kind of where this patient-centered decision needs to come into play, which is difficult because if you think probably, well, what if something comes back in 2 years? Then we're going to wish we had done the chemo, but you don't know what's going to happen in 2 years. And so that's kind of where you're stuck. But both options are okay.
Thank you.
Sure.
I'll say this, when I was a young, aggressive man, I had moderately differentiated mucinous adenocarcinoma, and I threw the kitchen sink at it. I've done all these chemotherapies and more. And if you were my dad, Mr. Blackburn, I might suggest, maybe Xeloda pill, the 5-FU, but I mean, the chemo is rough. Chemo is really rough. And I would say, just think long and hard about it. It's rough, especially oxaliplatin and the Folfox. It's tough. If you can avoid it, you'll always have it in the back pocket for, the next round in 2 years, because Dr. Gangi, tell me if I'm wrong, but it still is treatable in 2 years with HIPEC and other. So I think you keep that arrow in the quiver. That if you were my dad, that's what I would say.
Another question, and Dan, yeah, I was actually just getting to your question, but would you like to ask it?
Yeah, I think I would. I was diagnosed in December or November of 2019. In June of 2020, I went in for HIPEC, and it was stopped because of cancer in the small bowel. And I totally understood that. And I've been on chemo ever since with minimal side effects, I would have to say. I've been at least my surgeon says I'm in the top 10% of handling chemo. But the cancer in the small bowel has never, ever, since November of 19, appeared on a CAT scan. And my question is, would HIPEC alone, since it must be so small, maybe half a centimeter, I don't know the dimensions, would HIPEC alone kill the cancer in the small bowel? If it is so small, has been so small, and still not detected in a CAT scan. That may be a dumb question. No,
there's no such thing as a dumb question. And I wish I had a perfect answer for you, which I don't. But I'll tell you the one thing that we hate most as surgeons is backing out. So typically if we've done that, it is with good reason and hopefully a lot of thought. Because I don't think any of us enjoy that. It feels like a failure, and I don't think anyone likes failing. So, but potentially what they're seeing on your small intestine now, it might be a centimeter. The way to think of it is you can have something like a marble, right? And that can be, there's different sizes of marbles. But there can also be disease. And if it was a marble, typically you'd see it on a scan because it has kind of discrete round edges and things of that variety. Typically when we have to abort a procedure secondary to disease involvement on the small intestine, it's like a carpet of tumor. And it might be either a centimeter in length, but I don't imagine, because if it was a centimeter in length on the small bowel, then essentially you can just cut out that one segment of small intestine. So based on the description of what you're giving me, I can only imagine that there's probably a very, very thin layer coating a majority of your small intestine.
That's correct.
To the point that they can't cut out the parts that they need to cut out and leave you with enough small intestine so that you have a good quality of life.
And HIPEC wouldn't kill that.
Yeah, so the HIPEC typically will kill something that's under 2 millimeters. 2 millimeters or less. So it has to be essentially a quarter of a centimeter or less.
Dr. Gangi, do we see a day where Bromac can help dissolve the mucus, and then PIPAC maybe can, with that repeated attack, maybe drive that tumor down?
I think for an adeno CA, they feel and behave very differently. the lamins and the mucinous stuff, I think the Bromac can certainly break down. I don't see Bromac having a role in the adeno variant, which is, it actually sticks, it like grows into whatever it's touching, as opposed to being able to peel it off. So the way I typically will try to describe it is, if you gave me pasta with tomato sauce, right, on a bunch of noodles, and you said, I hate tomato sauce, get it off. Well, if I sit there and take every noodle and clean it off, I can actually clean it off, right? It's not terribly fun for me, but I can do it. And that's kind of your mucinous, non-invasive cellular component that comes with the lamin and the hammin. The adenocarcinomas, you actually can't get it off. It's like as if I put the pasta in cement and then you're telling me to take the cement off. I would damage each individual strand. And so the Bromac's not going to do much in that sense. PIPAC may be something that you would potentially be eligible for. So I think City of Hope currently has a trial, and then Northwell,
Yes, Long
in
Island.
New York. Yeah. So that would be a consideration, because that's exactly the type of patient in whom we think the PIPAC could be helpful, because it just sits there and it penetrates. And if that can shrink a little bit of it, that could be helpful.
Thank you very much.
Sure.
And maybe staying on the PIPAC theme, that there's another question in the chat asking if you could review again when PIPAC is recommended, and is it something that could be done when CRS was not successful?
Yeah, so PIPAC currently is done on trial in the US. It's done for a variety of adenocarcinoma subtypes. When I say a variety, meaning colorectal, ovarian, some appendiceal patients. Generally, it's in patients who have failed first or second line therapy, meaning we've tried chemotherapy at least once or twice and it hasn't improved. And then it, to a degree, depends on how much disease you have and where it's located, because we have to feel that the PIPAC is actually going to be helpful to that case. So each institution has slightly different variations on qualifications for the trials. But typically it's not a first line approach, meaning you just got diagnosed and someone told you you're not eligible for HIPAC. If you go to one of these centers, they're not going to say, sure, we're going to enroll you for PIPAC because you haven't really tried any of the other things. So typically it's a second or third line therapy. Does that help?
Yes.
Oh, and I think there's another question that says, when do we think it'll be available in more than one place in the US? The difficulty with the US is we have unbelievably stringent controls at the hospital level. So we've been trying to get it approved. It hasn't, COVID certainly didn't help us, but like air filtration systems and training and the power injectors. So there's 50 different things that we have to go through with environmental services to make sure that if there is chemotherapy that escapes, that we have the right filtration system in place, and it has to be an X type. So every institution has different variations. And then when COVID came into play, because there were so many other things to consider, all of the centers that were trying to essentially start PIPAC programs, that was kind of put on the back burner. That's being reintroduced. But it's not so much an issue of, are we able to do it surgically? It's the 300 regulatory issues that need to happen in order for us to have the appropriate anesthesia team, the room, the power injector, the filtration system, et cetera, et cetera. So those are the limitations. And City of Hope had initiated trying to get their PIPAC program in place about 9 years ago when Dr. Burnley was still at City of Hope, which is why they were actually able to start it 2 years ago. So
Wow.
it's at least 5 years coming for most of us, probably, hopefully faster, but that's the issue.
Chris?
Amazing. The small bowel transplant, what are your thoughts on this new approach?
Highly selected patients and highly selected centers, not opposed, but again, has to be for the right reason by the right expert. And typically for a majority of cancer patients, when we think about transplant in general, whether it's a liver transplant, a small bowel transplant, you essentially need to have no progression of disease, have no disease outside that area that we're transplanting for at least 6 months to a year. So you have to have stability for a prolonged period of time before you could be considered. Because the thought is, if we take everything out and put something new in and you were having progression of disease, it'll just come back.
Sure.
I was just wondering about, we hear a lot about people having chemotherapy, especially for high-grade disease after their successful CRS HIPAC. If someone is physically not ready for that, is there a time period where it's just, you should just get to the point where you should just do watch and wait? Or is it still effective to do it even 6 months or a year or 2 years down the road?
Yeah, no. So typically we would want you to start within 8 weeks of surgery. And again, this is all data that we have from colon cancer. We think the maximal benefit is within 8 weeks of surgical resection. And sometimes we extend that to kind of the 3-month window because the recovery can be difficult. But ultimately after the 3-month window, we think the efficacy kind of decreases fairly significantly. So not at a year or 2 years, there's no real benefit there. And then I think, realistically, you may never feel physically ready for adjuvant chemo, especially after going through this. I think it's a daunting procedure, and it's something that you just sometimes have to wrap your head around. But I think in working, depending on what you're dealing with, right? So sometimes we can't start you on chemo because you have a fistula or you're not healing or certain other things are happening where chemo actually is going to set you back. Sometimes you just don't feel strong enough. You're not eating well, you're tired and all those things. And you think, well, if I had chemo, then I'm not really sure how I'd get out of bed. But the reality is in talking to your provider, sometimes they can give you a modified dose to start, maybe a lower dose of treatment within that time frame, and then either build you up or back you down if you're not able to tolerate it. So there's some modifications that could be made. So I think if you're being recommended to have it, kind of talk about some options in terms of, can I start something different, lower dose, et cetera, et cetera.
Great, thank you.
Sure.
Marav?
Hi,
ctDNA.
sorry. Yeah, I have a few questions. One that I didn't wrote, but I really want to hear your thought on that. So normally, it was given a FOLFIRI Avastin. But what do you think about that post-surgery? Is it something that is dangerous to get following the CRS and IPEC?
No.
No, so it's recommended along with the FOLFIRI to get it?
Avastin?
Avastin, yeah.
Yeah, you can get it.
But when you recommend it, so you recommend
it could be pre or post-op. It doesn't matter. Some patients, some oncologists are concerned about risks of perforation post-op, but typically we don't start you on Avastin within a 4 to 6 week period. So usually the healing should be complete at that point. But yeah, there's no downside to getting it necessarily.
Okay. And another question is, what is the time frame to do the first scan after the surgery? Because the imaging can be, because I heard that a PET CT, for example, is hard to detect after surgery. So
typically 3 months for an adenocarcinoma.
Mm-hmm. And then last question, what do you think about the ctDNA, the Signatera Guardian 360? What do you think that the reoccurrence of the mucinous type is something that can be detected?
For Lamans and Hammonds, we don't think that the Signatera DNA is terribly helpful. For adenocarcinoma, based on colon data, we think that there could be a role, but we don't know exactly what that role is and how much disease volume you need to have. So currently under investigation, certainly something that could be useful if it's detected, but not a fail-safe and only reliable source.
Okay, and last question. Is it something that is can be done to have a lap surgery, let's say 1 year after the CRS and IPEC, just to see what is the real situation?
Yeah, so there was a trial that looked at that, ColoChip trial, in patients who were considered higher risk for peritoneal recurrence, and it didn't really show necessarily a benefit in having laparoscopic surgery, but I think it's something you can discuss with your team. And I think, I've had patients who have asked me the same question, can we just take a look in? The reality is sometimes after the cytoreduction and HIPEC, it's not as easy to get back into the abdomen. And so there's potential risk just in trying to safely get into the abdomen based on the scar tissue and how things heal. And so you have to kind of recognize the risk benefit ratio of each.
Okay, thank you.
Sure.
Paula?
Yes, good morning, doctor. Thanks for your presentation. I'm going back to the question that Luann just asked you about when to start chemo after the CRS HIPEC, and you said do it within 6 weeks or 3 months. Otherwise, it has less efficacy if you start it later than that. Is that right? What if you did start it early on, but does it lose its efficacy? For instance, does 5-FU lose its efficacy over a long period of time? that you've taken it. I've taken mine since every 2 weeks since January 2017 surgery. And in your opinion, does the 5FU lose its efficacy as you go along or not?
Yeah, not necessarily, and that's always a challenging discussion because we different patients react differently and respond differently. And so sometimes if something's working, the question is why change it? And at the same time, the thought is, well, if there's nothing that's changing, why not stop? And the risk of stopping is sometimes, well, what if something grows, right? You can always go back on it. But as far as we know, it shouldn't really lose efficacy as long as you're continuing to tolerate the drug.
Yeah.
So a lot of the times we'll stop because you just can't tolerate it anymore.
Right. I tolerate it very well. And so that's a discussion that I have with my medical oncologist. And you just backed up what I think. If it ain't broke, don't fix it. Okay. Thanks so much, doctor. I appreciate it.
Sure thing.
Aziz?
Yes. I have a question. Hi, everyone. Would like to ask about I was talking with many doctors for lamin, low-grade adenosis neoplasm, to follow up with laparoscopic, just for follow-up because the CTs or MRI cannot detect the disease in early stage. So they don't like to do even the small procedure. It has some complications. They will not do it unless something show in CT. For me, I had perforated appendix with a small amount of acellular mucin. So they say they have a low chance to have the pseudomyxoma in the future, but I have to follow up with CT, and they always say we hope it will not come back. What about laparoscopic procedures? Just do it at the first year or second year. And if there is no disease, we can stop follow-up doing CTs for 10 or 20 years, just to make my mind rest.
Great question. The reality is that even a laparoscopy, right? If there's something at a cellular level, we're not going to see it. So even if you do a laparoscopy and that doesn't show anything, that doesn't mean that there's some kind of cell that isn't sitting there. And typically, because this is so slow growing, you may not pick it up necessarily within the first year or the second year. So the optimal timing of doing a diagnostic laparoscopy would be obviously of importance. But I don't think just by doing that in a year from now, you can say that you're just not going to have any scans for 20 years, because like I said, our vision is not that great. CT scans are not that great. So you want to use everything in your power to make sure that this doesn't come back, because if you were to pick it up earlier, then the intervention would potentially be less difficult for you to tolerate if you needed it, as opposed to coming back in 20 years and saying, oh my gosh, look, we have all this stuff. And if we had done the scan 5 or 10 years ago, then, maybe we would have found it sooner and it would be a small operation. But you could do a combination of the two, but I don't think one prevents you from having to do the other, unfortunately.
So you mean doing laparoscopic for the first year, then wait for 2 years to do it again, or just one time and complete follow-up with CTs?
No one time and complete. I think that's the bottom line. Is there's no do something once and then never think of it again in the setting of what you described for you.
Thank you very much.
Thank you. There was another advanced question that I didn't get to yet. It's a patient with goblet cell adenocarcinoma. She has 2 questions, trying to figure out if all appendix cancers are automatically PMP. And then the second question is questioning why KI67, which you're probably more familiar with than I am, is not considered with goblet cell adenocarcinoma.
No, all things are not considered PMP, and I showed you that exhaustive table that again takes a whole hour to go through. So I'm just going to leave it at no. And then 2, why is KI67 not considered? So goblet cell adenocarcinoma is known to be one of the more aggressive subtypes of appendiceal adenocarcinoma. Ki-67 is something we use in some different cancers, but we don't really look at it in things like pancreas or colon or gastric or things of that variety. So it's not terribly useful. It's just a proliferative marker, meaning it just tells us how quickly things can kind of replicate. And typically we anticipate for a majority of adenocarcinomas, the Ki-67 is a little bit higher. So it doesn't really it doesn't give us a different option for treatment or anything of that variety, which is why we don't look at it.
Okay, thank you. Well, we are actually past time. Dr. Gangi, we can't thank you enough for this wonderful presentation and the time you spent with us this morning.
Sure, thank you. Happy to be here.
Yes.
Thank you, Paul.
Yes, Paul. Any parting words? You're on mute.
I just wanted to read something to you that I just received as a text. Paul, thank you for the invitation. We learned some new things, and as always, we're floored by Dr. Gangi. We feel incredibly lucky to have found her. And that came from Susan and Kelly.
Yeah, that is awesome. This was amazing. And thank you all for joining us today. And please remember to stay in touch with us. We have another support call this Thursday, 6 p.m. Eastern. Hope you can join.
Thank you, Dr. Gangi.